What I want to talk about are factors that affect the delivery of these specialist services. I hope I've made the case that these specialist services need to exist. What I want to do is talk about the factors that affect the delivery of these services and think a little bit about where the PAS 150 might help us. And I've got a list here of 8 factors affecting the delivery of specialist services, and it may well be that by the time I get to number 6, I will lose the will to live and get rather depressed. But I will try not to do that. So, let's start, before I go on to how services are commissioned, to think about what PAS 150 says around service design. It goes on and it says, services should be designed to take into account the need to protect the user. The provider should ensure that all biological, functional, social, psychological, vocational, financial factors affecting any service user are taken into account during assessment, planning, and service delivery factors. So here we are, we're designing a service. Does the commissioning process, which affects the way these services are designed, how does it impact on it? Well, one of the problems is the commissioning process is complex, particularly if you're looking at spot purchasing for these low-volume, high-cost patients. And so you can get a patient who clearly needs to go to a specialist service, and we want to protect them. We want to make sure that they get all the services they require, and the commissioning process can take 3 months while they sit in an acute hospital bed. So we have a commissioning service, a commissioning process that actually doesn't necessarily meet the needs of our service users. And what we need to do is we need to have a much more flexible system for commissioning. We need to get clinicians talking to commissioners, and we need to be able to move things on much more quickly than they currently have. I've got a little list there where commissioning difficulties have been reported. So specialist outpatient services, specialist inpatient services, vocational rehabilitation units, and complex specialist inpatient services. So that's pretty much everywhere. Okay, what else affects specialist rehabilitation services and the delivery of them? Well, the next thing is bed availability. Now, the Royal College of Physicians thinks that we need about 60 beds per million patients for rehabilitation medicine. If you go out and ask the clinicians, they feel happy when they have 70 beds per 100 million, and that's per million, and that's probably creative tension. In reality, what we have are about 40 rehabilitation beds per million. So there's immediately a resource issue. And if we increased these bed numbers, then what would we do? Well, we'd be able to shorten our waiting list. We'd be able to prevent this repatriation I was talking about. We'd decrease length of stay. And we'd decrease any risks of hospital-acquired complications such as contractures and pressure sores, which are more likely to happen in very busy medical wards. And that's in no way a criticism of these wards. They are delivering an enormous amount of acute care. Okay, I'm going to go on then and think about discharge pathways. And the PAS 150 says, services should be designed to be of high quality and efficiency with considerations for speed, timeliness, and cohesive connections to local community resources. Well, one of the factors that affects specialist rehabilitation services is our ability to discharge patients. On a survey of the membership of the British Society of Rehabilitation Medicine, discharge arrangements were only felt to be good for 42% of units. And problems arose, and I think this is perhaps unfair to talk about poor collaboration, but problems arise when social services are stretched and they're having to prioritise. Patients in hospital are safe, patients out in the community may not be. So when social services are having to make priorities, they may not look at those patients in hospital. Again, this phrase, poor collaboration with community rehab teams, may be the wrong phrase. Many community rehab teams are grossly under-resourced. They do not have psychologists, and there are not enough therapists, and they have their own long waiting lists. And we don't have any levers in rehabilitation in order to try and redress this balance, because currently rehab units are exempted from the Community Care Delayed Discharges Act, which if you're on acute ward, you issue a Section 2 and a Section 5 form, and that says your patient's coming home, you have to respond within a fixed period. Once the patient's in rehabilitation, you don't have to do that. So you get into an interesting situation where you may get a patient who's had 6 months of specialist inpatient rehabilitation where they've had 2 to 3 hours treatment a day, and they are discharged home, and they sit for 6 to 8 weeks on a community rehabilitation team waiting list because that team is not resourced to pick patients up at the point of discharge. And that doesn't really make sense. So the PAS 150 statement, the one that said they should be designed to be of high quality and efficiency with cohesive connections to local community resources, we haven't quite got there yet. So I've got a typo there. Service delivery. Financial and human resources should be available for continuous service delivery and sustainability. So let's look at another factor then. One is access to level 1 complex rehabilitation. These very specialised rehabilitation units, the ones that take people who have severe memory problems, the ones that take people who are very, very dependent, we have enormous shortages of these services. And the reality is that these services themselves are limited. So what are the figures I've got here? 2/3 of units will accept patients with some behavioural problems, but usually with limitations. So if a patient has severe behavioural problems, they have to sit on a waiting list for a specialist unit. Less than half of units are able to manage mobile, cognitively impaired patients. And my unit I would put amongst those. We do not offer a secure ward environment. I have had one patient go out and play with the buses on Southampton Row, and I never want it to happen again. It's extremely frightening for the clinicians, and it has potentially poor outcomes for the patients. Mobile, cognitively impaired patients need particularly secure environments. And if you can't offer those, you can't take them. Half of units say they have inadequate psychology input, and I have to say I think that's a real problem. Nobody wants to have vacant physio posts when you're short of money. Keeping a vacant psychology post doesn't seem to cause nearly so much grief. Only 1/3 of units will accept patients who are in vegetative or minimally aware states, so they have to wait for specialist units such as the Royal Hospital for Neurodisability in Putney. And so the waits for many of these complex specialised services are long, and in many cases inappropriately so. So if we come back to this service delivery one, financial and human resources should be available for continuous service delivery and sustainability, and we certainly aren't there yet. Another aspect in terms of resources is there's a shortage of consultants. It is around about this period I get very depressed, I have to say. So the Royal College of Physicians recommends 6 rehabilitation medicine consultants per million of the population, and 1.4 whole-time equivalents for every 10 level 1 beds. The present consultant level is about 2 rehabilitation medicine consultants per million of the population. And 2/3 of those are in single-handed practice. So we have a national shortage of consultants in rehabilitation medicine. And development of community services, most community rehabilitation teams do not have access to a consultant in rehabilitation medicine. Is this bad? Well, one of the things that's really worrying is we expect in this country not to have many doctors. I mean, it's the way the service is set up. But not only do we have fewer doctors than elsewhere, such as France, Germany, Sweden, and Italy, but we have a smaller proportion of rehabilitation medicine doctors within that total number. Okay, so outcomes. One of the things that I think affects our ability to deliver specialist services is to demonstrate benefit. People are very keen on us demonstrating benefit, and outcome measures are really needed as commissioning benchmarks. And we don't yet routinely collect outcome measurement data. Now, most of the units now do it individually for their own audit purposes, and we are just beginning to get to the point where people are beginning to collect data more systematically, really with a view to setting up a UK Rehabilitation Outcomes Centre, and really with a view to looking at both the inputs required to deliver good rehabilitation as well as the outputs from it. And the PAS 150 has something to say about this. Services should be designed to be outcome-driven. Performance should be demonstrated against key performance indicators. And program targets should be identified and built into delivery mechanisms.